It's really been a great pleasure. I'll be presenting our results on immune effector cell-associated hematotoxicity, or ICAHT, which has been an EHA EBMT-wide effort almost a year now to really define it as a distinct toxicity category of CAR T-cell therapy. And so hematological toxicity is a real problem after CAR T-cell therapy. It's one of the most frequent side effects of CAR T-cell therapy. It can predispose for severe infections. And one of the real issues is that the current grading systems don't really reflect the nature, the unique quality of hematological toxicity. And so for exactly this reason, we initiated first a survey to get a feeling, sort of what are the current practice patterns, what's the current grading. And I think we saw two really important things. First, that there's a very variable grading, and then there's really a high level of heterogeneity in terms of both clinical management, but also diagnostic workup. And so for exactly that reason, we got together an international expert panel, first met in a series of virtual teleconferences, and then in March of this year, actually in person in Lille, France, to discuss a novel grading system that we think mirrors the clinical reality a bit better. And that's sort of how this project came about. The grading system separates early versus late ICAHT. So early is within the first 30 days and late is after day 30. And then for early ICAHT, it's both the depth of neutropenia and the duration. And that's based on the rationale that this is really what drives infectious complications and is clinically relevant for our patients. And then for late ICAHT, it's after day 30 and it's just based on depth. And so by defining this in a very harmonized way, we can now actually generate management recommendations that are severity based. So for mild to moderate ICAHT, we recommend initiating G-CSF or anti-infective prophylaxis sort of based on the individual patient risk profile, whereas for grade 3 or higher ICAHT, that's sort of when we want to define a G-CSF refractory state. And once that is defined, we would actually recommend initiating hematopoietic stem cell boosts if they are available. And I think this now allows us to really tailor our management strategies based on the severity and to our patient presenting to for cell therapy. The question really also becomes sort of what are the clinical implications of a grading system such as this? I think what's really relevant is that this now allows us to compare ICAHT severity across clinical trials, which I think is really relevant. And I showed some data actually today where we looked at a retrospective cohort, about 550 patients. What is the influence of ICAHT? This is actually clinically relevant. And we found that patients that have severe ICAHT actually have an increased infection rate. They have really extended neutropenia, and they also have high non-relapse mortality. So I think that really helps us or underlines the clinical relevance of the grading system. And I think the grading system can be a blueprint or perhaps a starting point for now reporting ICAHT in a standardized manner across clinical trials in future. And so my hope is that maybe when we're here in a year or two, we don't only, when a patient presents to cell therapy or we see that phase 1 or phase 2 clinical trial, we don't just see CRS and ICANS, but we actually also see ICAHT grading and infections really reported in detail because these are really important side effects of CAR T-cell therapy.